We're here to talk about health reform and health IT and the intimate relationship between the two. In particular, to talk about accountable care organizations, which are really the linchpin of health reform as part of the Affordable Care Act. So the concept of the Accountable Care Organization, or ACO, is that it's a provider-side organization that has some aspect of risk associated with the cost and the quality of care going forward. Giving the provider, in this case both community physicians and hospitals, some responsibility for lowering the cost of care, some incentives for lowering the cost of care, because when those costs are lowered, they will actually get more reimbursement rather than less. Clearly, if we're going to change the dynamic in healthcare and try to bend down the cost curve going forward, we need to give some responsibility and some risk to the provider side for helping to accomplish that. If accountable care organizations are the linchpins of health reform, health IT is one of the linchpins of an accountable care organization. But there's a lot to do to get the health IT to the point where it can actually support this new notion of how providers and hospitals will come together to present and provide affordable care. Electronic health records, a major focus of this administration in the context of between $18 billion and $36 billion as part of the stimulus, that investment has largely been articulated as an effort to support health reform, to support the kind of activities that ACOs will be doing. But electronic health records have not been, as of yet, completely aligned with this vision of what ACOs can do. Take, for example, the idea of analytics that can show where exactly costs are high and where potential treatments or therapies or preventative behaviors can be applied better in association with those patients. It takes being able to analyze population data. Most EHRs still don't look at population data, they look at the individual data of a transaction of care. So very concretely, most EHRs have a hard time developing a list of patients who are on a particular medication, or a list of patients that have a particular chronic care condition. And those kinds of queries, those kinds of population analytics are going to be an important part of supporting an accountable care organization in its mission. Basically bringing together claims data and clinical data to analyze it, to find the sweet spots where costs can be reduced but quality can still be maintained or improved. One of the attractions of the ACO model is that one is putting community physicians and hospitals into a mode where they both can benefit from sharing those data versus holding them close. And that's significant progress. It is very tempting to try to look at technology as the complete solution to confidentiality and security issues around patient data. In fact, many health benefits accrue from having health information appropriately shared, however. And locking it up with technology, with all the challenges that presents, is not necessarily the best answer to have the best care and the best prevention of disease for the population. There are some very subtle and complex privacy and security issues that aren't all going to be addressed by buttoning up all data and making sure that those data are completely inaccessible. And we need to further the privacy and security discussion to tease out some of these more subtle areas. There are many examples where patient data are well protected, where when the patient is fully educated as to the value of having those information shared in specific ways, they are eager to ensure that those data are shared. And that's an important part of the conversation as well.